Well, thank you everybody for joining us at this panel discussion related to advancing care with EPCS, electronic prescription of controlled substances. My name is Santosh Kalkar. I head the prescription routing product vertical at Surescripts, and I'm very excited to have on stage some panelists here with great background in controlled substances. Dr. Sean Kelly, who is both an emergency physician at Beth Israel Deaconess Hospital and a chief medical officer at Imprivata. Dr. Rijav Pramanik, he's the CMIO at Contra, Costa Regional Medical Center in California. Paul Calatayud, our resident chief information security officer at Surescripts. So, gentlemen, if you want to take a minute or a few seconds to introduce yourself. Dr. Kelly?
Sure. So I'm Sean. I'm the Chief Medical Officer at Imprivata, and we've been working on electronic controlled substance prescription and controlled substances for over a year now, and have been involved in not just interacting with Surescripts and the various other complementary technologies, including the EMRs and e-prescription programs, but also a lot of the health provider systems, in working to make the technology usable and convenient, as well as compliant with the DEA regulations. Also a practicing physician, so I feel a lot of the issues firsthand as I'm caring for patients. Also have familiarity with some of the issues around checking the prescription monitoring program. And I think Rijav will be able to tell you a lot of firsthand experience too. So I think those are some of the angles that we would enjoy speaking about today.
Hi, I'm Rajiv Pramanik, CMIO at Contra Costa, but also I'm an ER doc. We put in EPCS. We're one of the first two Epic-based customers to put it in the nation late 2013. And we've had a lot of experience, and it's very I've never heard this, but our doc said it's actually the best implementation we did, which is surprising. Usually we hear a lot of different things, but that was the best compliment we've ever had.
That either means this was a great implementation or the other ones weren't.
I'm the Chief Information Security Officer for Surescripts, so I'm responsible for operational security as well as kind of helping influence the DEA as far as contributing to kind of what that position looks like, as well as helping our participants on our network comply with EPCS, and also an active voice in setting some of the policies for how our network is operating beyond EPCS, including e-prescribing, just to the basic prescriptions as well.
Thank you all. We all know the importance of controlled substances, and the level of accuracy, compliance that goes with prescriptions in general. Today, as of today, there are about 5 to 6% prescribers using controlled substances, and about 70% pharmacies who are ready for controlled substances within the country. So clearly, there's a lag of the prescriber community utilizing the controlled substances. And one of the things that is the contributing factor is EPCS is a very complex. There's a lot of information that goes into implementing controlled substances, right from mandates to technology to any other different state laws and regional or federal laws. So what it can be very confusing, not only for people getting into it, but even for experienced people who live this day and night. So we have great many topics here in the panel, and we'll go through that, which will help you as you navigate through controlled substances implementation and learn from some of the experiences we have here. Okay. So with that,
Can I correct you? We don't use controlled substances. We just prescribe them.
that's a good point. Thank you. So with that, I'll put you on the spot and ask you the first question.
For that, you get the first question.
Yeah, exactly. Thanks for raising your hand on that. So what's your experience in e-prescribing? You shared a little bit about the positive experience that you had. So tell us a little bit more. Like, what are the challenges that you faced, and how did you encounter? How did you address them?
Sure. I mean, it was very challenging before we did EPCS. E-prescribing in general was supposed to make things easier. Patients came and they were supposed to get their prescription sent to the pharmacy. End of the day, great. Well, unfortunately, patients came. Some things they got as a prescription, the controlled substances. Some things were faxed to the pharmacy, and some things were e-prescribed. So 3 different things now instead of the old, here's your prescription. So, so in its initial advent before EPCS, it was just a big confusing thing. Prescriptions got printed, some got forgotten because the faxed and the e-prescribes went through. So I think the EPCS really helped. It helped, so now we could send all your prescriptions in one manner. So we either e-prescribe it all, or we give them the prescriptions in a paper if we don't know their pharmacy. And bringing that together helps our patients tremendously. Obviously, there were challenges. The DEA ruling that said we could do EPCS, I think preceded the actual technology by 2 years or so. So the pharmacies all knew about it, and then they all forgot about it. So in the middle of the night, if they got an EPCS prescription there, some pharmacology tech would say, well, this is illegal. We don't get Valium, Percocet, middle of the, this is, you have to bring me a sheet of paper, and the patient suffered. So that was a little, at the beginning, but as we did that more and more, we worked with our different pharmacies in the community and their corporate systems. We got the information out, and now it's been fantastic. I would say if we did it again, what would we do different? We would like to put it all together at once from the beginning, but that's not something we can control.
So if you were to do it again, how would you tweak that, looking back?
And some of the things we learned, we in the first month we had a lot of these challenges working with the pharmacies, and then we developed a full circle method that we told the patient, we're doing this. If you have a problem, here's the person to call, and they would follow through. So we actively started following through, and we waited only a month. We initially thought just talking to the pharmacies and getting that information out there would suffice, but putting that in a month, we would have probably just put it in from the beginning.
Thank you. Dr. Kelly, for electronic prescribing in general, prescribers got on board very quickly. For controlled substances, there's been a little bit lag. Now, what do you see as the key barriers, challenges for controlled substance adoption?
Sure. There are 2 major issues. They fall under security issues and convenience or efficiency and usability issues. So on the one hand, the DEA ruling from 2010 set a very high bar from a security standpoint, and quite frankly, a lot of vendors weren't ready to fulfill the need and to become credentialed, because the whole system needs to be credentialed from start to finish and certified correctly to comply with DEA regulations. That involves a lot of moving parts. So not only is it the EMR and the e-prescription vendor, which is sometimes within the EMR and sometimes a third party, but also the authentication software and hardware that is used. And I'll probably talk a little bit about that in detail soon, because the authentication methodology makes a big difference, both for the security ramifications and the usability ramifications. But then also, as far as that software interacting with Surescripts, and then that message going out to retail pharmacies. Those are some pretty tough barriers, particularly when a lot of the EMRs weren't quite ready to address those early on. And then there's the culture change around it. So for every workflow that we do in healthcare, there's a big history of how that evolved. So changing that workflow, particularly in a situation and environment where the technology can be difficult and involve many different vendors, as you know, the theory that it should work is not always the reality. So it's a high-risk environment, and we're talking about very powerful medications with very powerful side effects, and a very loaded topic in clinical care. So that's a tall order. I think that the legislation in New York, specifically the iStop legislation, was a forcing factor for many people across the country, not just healthcare providers and healthcare systems, but the complementary technologies that all need to work together to get a system in place. we're talking mostly today about the software and the hardware that runs the action as I'm a prescriber and I go to prescribe something. But remember, before that even happens, I have to get credentialed. There needs to be a supervised enrollment where I enroll and put my fingerprint down and record it in the software, or I get distributed a specific hard or soft token. All those methods are, that's more layers of complexity and issues before you even get to the provider trying to perform the action of prescribing. So I don't think it's a surprise that there's a lag in adoption. The technology really hasn't been mature and ready. I mean, Rijav was way ahead of his curve and was doing this, among the first in the country. We actually turned to him to ask advice, to say, what are some of the lessons you learned and you heard about? And not surprisingly, once he got the technology figured out, it was the culture lag after that, where, from a regulatory standpoint, his system was complying, and the pharmacies actually were already certified and ready to take this. But at the corporate level, they had said they would take it. But that's different than when you send a prescription at 8:30 at night, right before the CVS closes, and Daryl is on, and Daryl hasn't heard, he didn't read the memo, right? So now he's doing something different than he's used to been doing for years. So quite frankly, it's not a surprise. It's now an exciting time because the technology has matured. As you said, doctors and prescribers, people are familiar with workflows around e-prescription in general, and they want to use it for a controlled substance because that's when we need it most. I don't want to expose my DEA number. I don't want to be exposed for fraud. I actually want to make it easier for patients that need pain medications, people that are in chronic pain, that have cancer, that are on hospice. Let them have their medicines. But please stop the drug abusers and diverters from getting it. And the system, the technology is the separating factor. The good technology enables all that stuff. The bad technology can actually be a hassle to use.
Right. Thank you. All similar to EHRs on the pharmacy side, what are the challenges that some of our participants on the pharmacy side face?
I think on the pharmacy side, it's challenging for them for a very similar use case around adoption of technology and understanding how to implement it. I think the difference is it's about developing trust with the receiving content. So I think I've seen a lot of challenges there, as well as how to really aggregate the data so that there's assurances that the identities that have been issued are trustworthy and that they're coming from trusted sources. So I think just to build upon this connected system, it's an end-to-end connected system, including the Surescripts network. So you have to maintain that integrity and trust all the way to the endpoint, to the pharmacy. And I think that's just a challenge for organizations to figure out how they're gonna achieve the accreditations, how they're gonna validate, and how they're gonna check for the messages, the content, and the verification of the identity itself.
Yeah, another part that's similar to what you've mentioned, we've experienced, where there's a lot of education that has to happen at various store levels. That somebody getting a prescription at 8 o'clock knows how to handle those. So in general, like Dr. Kelly, how would you say, what are the steps that EHR vendors need to take to implement EPCS? And specific, like if you could walk through some of the two-factor authentication technologies that are available, if you can highlight them, I think that'll...
Sure. I can speak to a little bit about what we see across the whole market, and then maybe Rijav could talk specifically about his experience. I think that it's the healthcare system needs to consider, again, that whole process from beginning to end. The one point in that process that may be the most vulnerable, but also the thing you can take the best advantage of, is around that authentication event. And if you can bury that authentication event and the security so it's invisible behind the scenes and allow the provider to live in their normal workflow. So if you can actually link that authentication software pathway to the actual EMR or the e-prescription module within the EMR, so that as a provider, while I'm in that workflow and I go to write a prescription, If I have two non-controlled substances and one controlled substance, the system is smart enough to recognize that. And when I hit the button, it knows to call out and say, okay, does Dr. Kelly actually have a fingerprint enrolled in the system? Does he have an OTP token that's a hard key fob token or a soft token or a smart card? But that's really not used in this country much. And can he use a password, which we can all use. So if the system knows that, and if there's the proper hardware plugged into that desktop that that person is on, it will offer that as an option. But if if that person is not enrolled, it shouldn't offer that as an option, and that's an airtight authentication mechanism if it's buried right within the workflow. If as a provider I'm doing prescriptions and that workflow is broken and I actually have to go someplace separate to do that, that's like the kiss of death, right? It's really hard for me to break concentration, open up another program to do separate e-prescription, a controlled substance, reload that, boot it up, remember another password, get into it, look up the patient. Is it the right patient? Is it not the right patient? There's room for error, room for frustration, satisfaction drops, compliance drops. So you need to make sure you're integrated into the workflow and it's useful, but also all the security is built into the features. There's one more potential that Imprivata, we just made a Bluetooth enabled, DEA certified, hands-free authentication method, which is like an OTP token, but it works without ever having to open your phone. So as a provider, I can register my phone ahead of time because it's a device that's unique to me. That can be my OTP token, and it can function like a soft token. I can open it and read it and manually put it in, but it could also just, the software can realize it's in my pocket, authenticate, and that's one factor completely done with without my really doing anything. So that's an example of convenient workflow, and that the convenience is what makes it usable and people comply with it. I don't know if you have anything to add.
I mean, that's kind of, anytime you have any clinical workflow, technology can't be a barrier to that workflow. It has to be in the workflows in the background, as Sean was saying. And with the stuff you guys are doing with this Bluetooth, it's basically totally invisible. For you, you can concentrate on the med, is the right med, it's the right dose, not how to transmit the med, but making sure the patient should be getting that med.
What did you guys choose for like your methods? Because you didn't have the Bluetooth thing available. Like, what did you do? Which methods did you use and where?
So we did kind of a user group meeting. We had a bunch of docs come in and try different methods, and they went with the fingerprint and then a soft token on their phones, which now with this Bluetooth, if the phone is having the soft token, it can be totally silent. Right now, depending on the technologies, the fingerprint works for most people, but if it doesn't work always, then they have the backup. Mm-hmm. But I mean, they've been, again, best implementation I've ever done, supposedly, without doing much.
Right.
Do you want to mention the two innovations we did with the virtual machine for remote work and the daisy chain?
Yeah, I mean, these are, again, things where EPCS really help. These are kind of technical things, so basically, normally controlled substance can only be prescribed for 30 days. With these daisy chain, you can actually now prescribe it 3 30-day segments up to 90 days, so the prescription is predated. We work with Surescripts and the DEA, and that's all okay. So that's the daisy chain, and it really helps for patients with such as your ADHD kids. Having them not on their meds is not a good thing for those parents, right? They're running around in circles in the clinic, and you're just trying to get that prescription. And so missing prescriptions like that, or cancer patients, it's not a good thing to have.
Right. Well, when we talk about technology, there's always investments. And investments, administrators get a little bit concerned about investments. Share some of your thoughts, Paul, Dr. Kelly, yourself, Dr. Pramanik. When somebody invests in this technology, what other uses can they have besides just electronic prescription? If you can share some of your thoughts, Paul, and then I can ask you guys as well.
Yeah, hopefully I don't steal some thunder here, but prior to Surescripts, I operated in provider and payer Fortune 20 companies, so in a security capacity. So what's interesting about what I think this opportunity is if it's done, like you said, within a seamless ecosystem, if it's part of a core authentication, if it's embraced as a capability within an IT organization and in a clinical environment, I think what you end up having is opportunities, right? So as I see them, some of the opportunities are addressing additional risk factors. For example, a lot of concerns that I've experienced is walkaways, doctors walking away from their kiosks. You know, these are considered trusted EHR systems, and so you implement a strong authentication only to see the reality of that being completely or exposed by having a doctor walk away, and you just look at a kiosk ready for abuse or fraud or various things like that. So I think there's the opportunity that some of the technology that I've seen is to make it seamless, introduce single sign-on, introduce kind of multi authentication strategies using these core products like Imprivata, and what you end up having is a actual advantage in addressing risks that I spoke about, as far as how you create attribution, continuous improvement around making sure the doctor's in front of this device, and then allowing for these infrastructure investments to be used for actually enabling more frictionless transactions in the EHR and beyond the EHR. So I think that's a very important thing to be thinking about as you make EPCS investments, is be thinking about, do I make it as in a standalone infrastructure application workflow, or do I invest at the heart of my ecosystem in ways that basically this identity can be leveraged for multiple transactions and multiple applications? And that, I think, is probably the biggest thing to be thinking about when we make investments.
I mean, for me, from a patient-centered perspective, the technology can be leveraged for signing on, confirming, but it just decreases the delay from patients getting their scripts. And I think when in the world of HCAPs, CGCAPs, and patient satisfaction rates, anything we can do for them to get the right med as fast as possible is paramount to get our patients good care.
I would totally agree with that patient satisfaction increases. You mentioned, using authentication and workflow optimization. That's a core issue throughout almost all of healthcare and IT. And, you're well served to consider, like Rijav did, having a committee or having an active dialogue between clinicians and operations in the hospital, as well as the informatics teams, to try to streamline those effects. And it's always traditionally been a balance between security and convenience, and the reality is you can kind of have your cake and eat it too if you use good authentication technology, and that technology continues to improve, and it will continue to improve. And whatever is out there that is the best in breed, it'd be good if whatever systems you have allow you to bring that in, whether it's voice or retina or palm vein or a combination of those things. There will always be, hopefully, better and more methods to get people on systems in a more secure and a faster way. The idea is, how do you balance those in different parts of the hospital? How do you figure out where that workflow would most benefit from a higher level of security without blocking the user? Or do you lighten it up a little bit if you're behind the scenes in an area that's already kind of secure and protected? And figuring out that balance, security is a continuum. And convenience is a continuum too, and it's a balance between all those different things. It's in some places more of an art than a science, kind of like medicine, right? Mm-hmm. You have to apply those same skills and that same methodology. I mean, we have over 2.5 million healthcare users logging on and off and using different authentication methods completely unrelated to EPCS, but EPCS requires certain stringent ones according to the DEA, so it's got a slightly different twist to it. But it's still the same theme all across healthcare, and I'm sure everybody that touches the topic understands that in a way. And it can burn you, or it can make you, it can make your users really happy if you do something for them instead of to them.
Yeah. And this was my signature before.
Yeah.
So it's basically two signals. So we have all these secure scripts with this signature. It used to be one circle, and the ER clerk said, "Oh, that's taken." So on all these controlled substances that I was prescribing before, it was one circle and a printed paper with all the narcotics or what have you in the world. And I think that's another area of, you're confirming, this is a much better confirmation all this technology in the background is doing, making sure no one else gets that printed sheet of paper and then starts circling and giving it out.
Thought you were going to go say by two circles it's the two-factor. One circle is the one factor. I thought there's something there.
Maybe the next Indian guy will have 3 circles.
There you go. So, Dr. Kelly, you mentioned something about New York, like the regulation in
Yeah.
New York
Yeah.
earlier. A couple things. Tell the audience what it was a little bit, and have you seen something similar in other states? Yeah.
So the iStop legislation was a New York state law put into effect saying all prescriptions need to be electronic, whether it's controlled or non-controlled substances, was due to go into effect of March of this year, got delayed by a year. So it's a law on the books, actually passed almost unanimously. I think it was unanimously by the New York state legislature in response to the public health crisis that is opiate overdose addiction, diversion, and abuse. So it's rare that a day goes by all across the country where there's not something being written in the papers. There's enormous pressure on politicians and on us as a society to curb this issue. More people die every year in the United States from prescription drug overdose than car accidents. And a large portion of that is prescription overdoses of opiates. And that doesn't even include heroin, which we know is, many people bridge to heroin and get started with controlled substances. So there's a huge problem. There's a lot of focus on how we solve it. Part of solving it is stemming the tide at the beginning. So using electronic systems to prescribe controlled substances is one prong of that. Another prong in the law, as elaborated by the legislature, is that all the providers, before they prescribe controlled substances, are supposed to check the PMP, or prescription monitoring program, for their state. New York is the only place to actually have put that into law, but we're hearing from many other states that there's great interest in mimicking that process. I think we've heard, you'd mentioned Maryland. I know in Massachusetts there's been a law that's been proposed, has not been voted on or debated yet. But there's a lot of interest from many branches in government, and it's a bipartisan issue. So we feel like that we are constantly speaking with the boards of pharmacies, whether it's on a national basis or on a state basis, with many different aspects of the government. There's great interest in figuring out how to solve this. I think there's also acknowledgement that technology is a factor, and again, good technology is different than bad technology, and that being compliant with the DEA regulations is at the core of all of this. So those are themes that are, again, they're no surprise. These aren't easy issues, but there's a path to the solution that has been proven out in large part due to this legislation forcing the issue in New York, and then nationally now the technology and companies being more ready to address it, and healthcare systems in a very, much more advanced way are thinking about it and talking about it. And we've had, literally probably hundreds of discussions already between pre-meetings and at HIMSS now about this topic. So it's a very, very topical issue.
Do you guys have any other insight into some of the state regulations that are going on?
Well, after New York goes, I know California will go, and then the rest of the world will follow, obviously. Yeah.
Yep.
Oh, great, thank you. So clearly, one of the things, like I mentioned earlier, and what you've heard here, there's a lot of collaboration that needs to happen with different parties. What I'm going to ask each of the panelists is, how can we work together? Like, as you're wearing multiple hats, as a doctor, as a prescriber, as a technologist, as a user. How can we work? So if you want to go first, and then each of us, let's talk about how we can make this a better experience for all of us.
Sure. I mean, I think the different vendors, first of all, need to get together behind the scenes, and there's a lot of homework that needs to be done, and it's ongoing. We're doing it right now. I know that we, as the authentication software vendors, are working actively with just about every major EMR vendor and e-prescription vendor and a lot of the hardware vendors that are involved. So that needs to continue to happen, and that needs to happen in conjunction with the healthcare systems to understand exactly what they need. There's no sense in creating a solution that's like 3 feet to the left of what the healthcare providers are actually looking for. So workflow analysis needs to continue in parallel to technical analysis, and that involves the technical people at the hospital level working with the providers at the hospital level, as well as workflow people at the vendors working with the technical people at the vendors. That's a pattern that has been successful in many places before, and I think that's a pattern that's playing itself out again now. I don't know what your experiences are, but we're actually very enheartened by the progress that's been made. I mean, really over the past 6 to 9 months, things have changed almost completely in our view, where we went from systems that were really miserably behind to really working systems now. And we have customers that are up and running and active on this and very, very pleased, making providers very happy, and more importantly, patients really like to not have to go to their doctor and get a paper copy when all the rest of their scripts got sent over and they're already sitting there waiting for them at Walgreens. Now the same thing happens and they really like it. So people are increasing their satisfaction scores for this piece alone.
Yeah, and especially in the advent of e-consults and e-visits, remote ability to see the patient visually and then prescribe that medication for not in the more chronic usages of anti ADHD medications. This really gives you that. Does the patient really have to come see you 30 days for some of these things? No. Should they just to pick up a piece of paper with 2 scribbles on it? So it really, the technology is profound in certain changing ways for our patients.
Being at the network level, it's kind of an interesting place to be as far as looking for and contributing to help. So I think from my view, I think what I'd like to have a better handle on is what's working, what's not working, what are some of the barriers and challenges, and start working with the vendors and the service providers on how to come up with kind of maybe more of a turnkey solution. Surescripts is very neutral when it comes to what that end solution looks like, but I definitely want to start to get a better understanding of what is working and what's not. What vendors are strategic in contributing to this solution and what are versus others that are probably just reacting to the market and maybe, as you called it, developing solutions that are 3 feet or 4 feet to the left. I think is it's important for us on a network level to understand that, because Surescripts is very much looked at as an advisor and kind of an authoritative source when it comes to navigating these things, good or bad. I think it's just a position we have and we need to continue to maintain. And in summary, what I'm saying is in order to maintain that situation awareness, there needs to be a feedback loop across the end-to-end solution.
And I'll also add that to take a point further, where Surescripts is viewed as a source of information, we have accumulated and posted a lot of information on our website. Late last quarter, our marketing department launched the getepcs.com. It's a website with all kinds of information to ramp up people from zero to getting them implemented. We maintain all the information about state, where which regulations, which of the states follow some of the IFR regulations, and who have been aligned with DEA. And so all the information, we also have the geo capacity to show which prescribers can prescribe EPCS, which pharmacies can accept EPCS. So we have heard from such input in past and created those kind of platforms, and we continue to do that. So that's another add that I would add.
Okay.
So well, that's all the time that we have for this panel. I really appreciate your time. I greatly appreciate the panelists. Thank you, Dr. Kelly, Dr. Pramanik, Paul. Your insights are great. Really appreciate that insight. I'm just going to open this up for a few Q&As at this time. People have questions.
I had a question.
Yes.
So, with the checking that we do with the state, California has its own registry, New York, Massachusetts. Has there been any state that's reached out to Surescripts to try to automate some of that? Because it's not something very easy to do, and if it's mandated to do every time and get a unique number like New York is encouraging, which I'm sure we'll all have to do. Is there some
So the states usually pass some of their regulations, and Tim, you can speak a little bit if you have more insight on that. But usually the states, once they pass it, to get those regulations passed, we get involved from our regulatory folks. They get very much involved with the board of pharmacies, with the departments, with the bill passage, or even helping the DEA or the individual state bodies to craft those regulations and help them with that. So we participated a lot in those activities and share some of the experiences that we have learned here. So that's how we engage with the different state bodies as well. And it has been very, very instrumental. Ken Whittemore, who is not here, but he's very instrumental in engaging with all states and all the board of pharmacies of different states to work through and push this system. Right?
As a follow-up to that question, what I wish is that there were NCPDP defined standard message for this type of medication history query, and that all the PDMPs had the same piece of software that you interact with. It's like, there's going to be 50 different ones, right? It's going to be a mess. So, anyway.
Just to address that, the state as it is now, the state of the states is that, you know, they're all separate. There is a PMP interconnect run by a third-party vendor that is helping to link into and make reciprocity across a lot of those states. There's still some issues with that, but it is up and available now. So that's something to consider, and that technology hopefully will continue to evolve. I think the issue is that a lot of these PMPs were set up years back. I mean, literally in the 1980s, many of them were created as a database to be looked at from a forensics standpoint. When you're looking back, the criminal justice system at some point will go back and look at someone that they're investigating, and they're looking at data that was placed in there, but it was never meant to be a real-time tool. It didn't evolve with or to any significant degree beyond a lot of the basic foundation that was created. So I think there's a knowledge out there that may be inadequate to what we're trying to use it for, to try to get real time or at least daily or hourly or whatever the best is we can get data to help look into these issues of abuse and diversion. So that's an area very much in flux. I look forward to seeing what happens with that in the near future. But I agree it's a pain point for many providers and systems at currently.
They should use Imprivata to confirm our ID when we're looking to that system.
Great idea, Rijav.
No, it's interesting. I mean, when we get our DA license, we do everything, and then to access it, at least in California, we have to do everything again separately with a separate agency. But it's not something new. So, because they were put in at separate times for separate reasons, and they're not necessarily connected.
That's a good point. Are there any other questions that we can take at this point? Okay. Well, if that's the case. Well, thank you again, everybody. Thank you for joining us.